Good afternoon, everybody. Thank you so much for coming on a rainy Friday afternoon. I really appreciate you being here. And it's really, in case anybody doesn't know me, I'm Ethel Kagan. I'm the Assistant Director in the IDGI Pulmonary Group. And it's my distinct pleasure today to introduce you to Dr. Chip Walters. I'm sure most of you already know him since he's been at Duke for a long time. He's done a lot of work on vaccine and other types of research. He is Associate Professor of Pediatrics. He's also in the Department of Pediatrics Division of Primary Care Peds and Infectious Diseases, and he's also very involved in the Department of Epidemiology in the Gilling School of Global Public Health. And so without further ado, I'm going to turn things over to Dr. Walter, and he's going to talk about a very, I think, topical topic, and that is H1N1.
Thanks, Ethel. I'm just going to start off. How many people were here? I did noon session a couple weeks ago. Mary was. Well, if you were here a couple weeks ago, I threw in a few different things because I knew I'm coming back and with the same people were there, kind of walking. I didn't want to give exactly the same talk. Many of the slides will look familiar, but I figured some of the audience will be somewhat different. And I focused it a little bit differently. The talk I gave a couple weeks ago was entitled the Vaccine Unit Update and also Influenza Update. So I said, well, maybe I'll change the title this time. So I was going to talk more about prevention of seasonal flu and H1N1 influenza. As Ethel said, I am a primary care pediatrician, so I do mostly outpatient pediatrics, see sick kids, and been seeing lots of H1N1 influenza. But the other part of my time is spent doing research, so I work in the Duke Vaccine Unit. We actually have with us here in your midst one of the very founders of the Vaccine Unit, Mary Maggio. When I first started working with the Vaccine Unit, Mary was the study coordinator with the Vaccine Unit before it was even called a Vaccine Unit, right, Mary? So she is one of the originals. Let's see, is this going to work? I know. Let me go this way. Oh. Am I locked? No, I'm locked. Okay, let me go forward. It's not going forward. I have to do my disclosures next, so maybe that did it. Okay. Does that do it?
You go ahead and I'll
Okay. Just quickly do my potential conflicts of interest. I do get grant support from a number of different industry sponsors. And I guess I probably should add the federal government as well. That probably is a little bit conflicted now. And I do some speaking for Sanofi and Merck as well. And if I can, okay. Right click. Okay, great. So before I start off talking about flu, I think it's always important to remember what the impact of influenza is. And you can see there, everybody is so hyped about H1N1 influenza. But I think we really need to remember that on average 36,000 deaths per year occur in this country and 226,000 hospitalizations due to influenza. So just because this is H1N1 and has potential for potentially affecting more people, I don't think we really should ignore the implications of everyday flu that we see each year. So before I start, I'm going to talk a little bit about the germ itself, influenza. This particular virus is an RNA virus, and it has 8 different genes. And there are really 3 different genetic types. There's an A, B, or C influenza. And when we're talking about H1N1, we're really talking about type A. But if you're talking about seasonal flu that occurs each year, you're talking about really both types A and B. And type C is really ever rarely reported in humans. When you think about the implications clinically for influenza, generally type A causes more moderate to even severe illness can affect humans and other animals, whereas type B generally only affects humans. And type B, we usually think of affecting more children. So in my pediatric population, seem to be more disproportionately affected from type B disease than type A. And the other thing that's very important when we think about type A is that it very frequently experiences that the virus undergoes a lot of genetic mutations or changes, and this is why we have to vaccinate every year. Whereas type B is really a lot more genetically stable, so there are not a lot of changes. This is a cartoon of the virus here, and you can see all the different RNA segments. But really what's important to notice are the surface proteins, viral proteins. And there are two that are of particular importance. When you hear H1N1, what does that mean? Well, it's really referring to the type of hemagglutinin, and there are a number of different types of hemagglutinin, and the type of neuraminidase. So if you're talking H1N1, you're talking the H1 type of hemagglutinin, the N1 or the number 1 type for neuraminidase. You might hear H3N2, which would be a different hemagglutinin type and a different neuraminidase type. Now, what are these viral proteins for? They're important for attachment of the virus to host cells in the respiratory tract, and that's particularly the hemagglutinin. And the neuraminidase is really important for viral release. Yes?
I just have a quick question. What is, if you go back a slide, grab the mic. What is what is type C influenza?
It's usually more affects animals, so it's not really important as a human pathogen, so I'm going to kind of gloss over that.
Oh,
okay.
Thanks.
But good question. And feel free to stop and ask questions as you go along. So I'm not going to, it doesn't really have a lot of importance for human disease, so I'm not going to spend time on that. Okay? And then there's another protein, which is the M protein, that I just want to point out here. As well. But the really important ones in terms of pathogenicity are the hemagglutinin and neuraminidase proteins. And these are the surface proteins that give rise to what we know as protective antibody. Some of the data that I'm going to show you today, a lot of it's really more focused on immunity to the hemagglutinin protein. And we really think this is the important marker for protection in influenza historically. But it may not be the only one. So how are these things named? Well, the World Health Organization has come up with a nomenclature for naming influenza. And if you look here, it is first named for the type of isolate, so A or B, or as you point out, maybe C. But in this case, since we're really only dealing with human isolates, we're going to be talking about A and B. The second letter here is Brisbane. That's where it's isolated. This is just really denoting the number isolate from the laboratory. This is the year in which it was first isolated. And then this last designation here is the subtype of hemagglutinin and neuraminidase. So here we're saying H1N1. Now this particular isolate here is actually a seasonal influenza. This is not the H1N1 that we're talking about. The H1N1 we're talking about is H1N1 California, isolate. So it's not, and it would be a 2009 isolate. So this is actually the isolate that's in the current seasonal influenza vaccine, which has 3 different strains in it. And this is the H1N1 that's in the seasonal flu vaccine. But I just wanted to point out how these things are named in case you see all these things when you're reading about it. Okay, so how is influenza transmitted? Well, it's usually transmitted by respiratory contact, from person to person. So it's transmitted by when we cough or sneeze, we, aerosolize these particles, and then you come in contact with the aerosol, and you potentially you will get infected. The incubation period is about 1 to 4 days. So after you contact somebody with disease that you come down with infection. You can also get infection from direct contact with respiratory secretions. So if somebody sneezes or rubs their eyes or whatever, touches here, then you go and you touch there and you rub your eye, which I'm not going to do right now. then you can potentially transmit infection that way. So that's why we talk about, hand washing is a good measure to prevent contagion. You can't always protect against this kind of thing that you're seeing up at the top of the screen. So once somebody is infected, how long are they infectious for? Generally, we consider that adults are probably infectious for about 3 to 5 days. Young children can shed virus for some time. They can shed for up to 10 days. And if you're immunocompromised, you might shed even a little bit longer. But that's from the time that right before you become symptomatic or right at symptoms or 1 day before until you stop shedding. Now, the general guidance has been this flu season is that somebody afebrile 24 hours can go back to work. Now, that's not afebrile on Tylenol or Motrin, okay? So we get parents that think that, but so that's afebrile without Tylenol, without Motrin. Kid needs to be feeling pretty good to go back to school. Now, you could potentially transmit virus, but there's probably less virus there at that point. But the young child still may shed some virus at that point. Obviously, if a kid's still coughing a lot, a lot of runny nose, you're probably going to want to send them right back to school. I think most of us know the signs of influenza: fever, muscle aches, headache, cough, sore throat, and runny nose. Children may get a lot more GI symptoms. They may throw up. And it's interesting, with the H1N1 virus, adults seem to be getting a little bit more GI symptoms. And that may be the fact, part of that may be the fact that when children get flu, it's novel to them. Their bodies have never seen it before. Well, just like this virus is novel in adults. So maybe, one could think maybe that's why adults are having some more GI symptoms with this particular infection. Usually, though, when I think of flu or influenza illness, I think of fever and respiratory symptoms. So fever and cough are really the hallmark symptoms for flu. Now, how do we diagnose it? This has been really problematic this year, particularly problematic. And why is that? Well, there are a number of different ways to diagnose flu. Well, you can draw blood and measure serologies, but you have to do it at the time that somebody comes in, and then you have to do it 2 to 3 weeks later. Well, that ain't going to help you. So that really is only good as a marker for infection in research, and it's a good marker that we use in vaccine studies. And there are a number of different assays that we use in research to look at responses, particularly to vaccination. So you're left with trying to isolate the virus. So you can actually grow the virus, but that takes 2, 3, 4 days. So that ain't going to help you if you're sitting in the clinic with a bunch of sick people. You kind of want to know the answer now. So there have been a lot of rapid detection tests that have been developed over the years and approved that take less than 30 minutes. Anybody can run them pretty easily. The problem with a lot of those assays is that they have very low sensitivity. So if you go to the clinic and you're sick, you may not test positive because they're not very sensitive. And the other issue is, particularly with this H1N1, we found out that the specificity was fairly low. So we had people testing positive, or kids in the spring testing positive on the assay, and we'd send over a PCR test, and they would be negative. So the specificity really wasn't very good as well, particularly if you're out of season. So these rapid tests aren't very helpful. You can do fluorescent antibody testing if you have a lab that can do that, and they're fairly sensitive in good hands. Again, you have to have the lab. And what we really have relied on is PCR testing, which takes, here at Duke, we send off a sample and we get it back the next evening. And so usually I get it back at 5:30, and then I'm calling parents the next evening if I've done a test. So who are we testing? I don't know that I put that in here. Really, I'm only testing for H1N1 certain populations, and I will. I don't know if I come back to that later on, but I'm really only testing people who are hospitalized. Although I don't work in the hospital too much, would get tested, or people if there's a really high risk condition. So if I have a child coming in sick and there's a pregnant mother, I think in that case it's really important to try and document. Or if I have a young child who's at high risk that I'm going to treat, then I would go ahead and potentially test that child as well. Now, I think when we're talking, I'm still talking about seasonal flu before I'm kind of jumping back and forth between H1N1 because I'm going to try and show you how, we've learned from seasonal flu to kind of extrapolate to H1N1. But when we're talking about seasonal flu, we always have to remember that the peak for seasonal flu usually doesn't come till February. And usually we start our vaccination campaigns September, October. So, in fact, you have a long time. It only takes a couple weeks to get an immune response. You have through January a lot of times to get your vaccine. But I can tell you in the clinic, by December, we don't want to see a flu shot. We are sick of flu shots. We've been giving them so long that we're really tired. The enthusiasm starts to wane. But, in fact, it probably shouldn't, and we really should be vaccinating people up until flu season, which traditionally peaks in February. Now, right now, I don't know if I have the curves for H1N1. We're peaking and coming down off that peak. I don't have this week's curve on there, which I'll show you later. But we don't know what's going to happen in the spring. Some people have predicted that maybe H1N1 will come back in the spring, so we'll die down and it'll come back. Some people predict that we'll have seasonal flu. Perhaps an H3N2 or a B in the springtime. We really don't know. If we see it, it probably will occur around February, which would be traditional. Now, as I mentioned, this virus changes a lot of genetic changes. And there are two ways it can change. It can drift, so you get really minor changes in the genetics, point mutations in the genes. And it does this every year. It changes pretty much a little bit. The virus strains change almost every year. That's why you have to get a flu shot every year, because the virus changes every year. So, it's one of the few things that you have to go in, and it's crazy yet. We haven't figured out how to get a vaccine that cross-protects against all these different strains, but we haven't. So that is the reason why you get a flu shot every year. But every once in a while, you get a major reassortment of the genes for these viruses that leads to a big shift in the virus, and that's what happened this year. We got a big shift in the virus. I'll show you a cartoon for the H1N1 down the road when I get more to H1N1. And the population hasn't been exposed to it before. The population isn't immune. That means more people are susceptible, and that's why we expect more people to get infection, more people to be hospitalized, and potentially more people to die than what you saw on the first slide. So the World Health Organization monitors this influenza activity every year, and they pick the vaccine candidates based on what drifts and shifts they see. And usually for vaccine for the Northern Hemisphere, they select that vaccine in February. But remember, this epidemic didn't start until, like April, May of this year, that we really first became aware of it. So the vaccine strains had already been picked for this year's vaccine. So that's why, the manufacturers were set and heading down that path to make these vaccines. So it required, to make an H1N1 vaccine, really retooling and thinking, making a whole separate vaccine. And each year they select two A-type strains. So it's one H1N1 strain and one H3N2 strain and one B strain go in the vaccine. So this year's vaccine strains for H1N1 are here. The H3N2, you see everything came from Australia, this year. But these are the strains. And you can see there was very little change between last year's vaccine and this year's vaccine. There was no change in the A strains. There was only a change in the B strain this year. So when you're talking about traditional flu vaccines, these are the current flu vaccines that are on the market for seasonal influenza in this country. and they're made by 5 different manufacturers. This is an Australian company that was recently licensed a couple years ago after we had a lot of shortages of vaccine. The U.S. government funded studies, of which we were part, to bring additional licenses or vaccines to market here in the country, because manufacturing problems seem to be occurring every year with the current manufacturers that were in the market. A recent change, the GSK product, or their inactivated vaccine, had an indication for over 18, and that now has an indication down to 3 years of age. If you're looking in the very youngest age group, from 6 to 35 months, there's really only one vaccine that's on the market. And then this last vaccine down here is a live attenuated vaccine. That's a mist vaccine. You all have probably heard of flu mist, and it is, and I'll tell you a little bit more about that. It's only approved for those who are 2 to 49 years of age. So these 2 vaccines, the inactivated vaccine is administered by injection. It's killed. It's not live. It doesn't cause the flu. As everybody always thinks, flu vaccine causes the flu. This is killed, dead, does not cause the flu. Okay, can be used for anyone 6 months of age or older. And really the only contraindication would be egg allergy, and potentially if somebody had a history of Guillain-Barré syndrome, which isn't totally common. It's fairly rare. Would be another person that I wouldn't give it to. The live attenuated vaccine has more restricted use. As I mentioned, it only can be used in persons 2 to 49 years of age, and I'll briefly mention that. Children under 5 who with possible reactive airways and people with asthma should not get this vaccine because it can trigger asthma attacks. Remember, it's a live attenuated vaccine, so you're giving that nasally, and it can cause a little cold symptoms, runny nose, stuffy nose. So we generally don't give it to people with asthma or anybody with a high-risk medical condition or pregnant women. Do you have a question?
Why 49?
49, that was just the age to which it was initially studied, so that's the indication it got. Why 2, I can probably answer better. It was actually studied at younger ages, and what came out from the initial studies are 2 things. One is that if this phenomenon of higher rates of wheezing, particularly if you had underlying or had prior wheezing episodes. So that came out in the wash when they did the study. And then the other thing, young children seem to have higher hospitalization rates, not necessarily for wheezing, but all types of hospitalization rates. So that didn't seem to be true if you were over 2, but for those under 2, it did. So therefore, it was decided not to approve this vaccine for those under 2. So these vaccines are both effective for kids and adults. And what's interesting, if you look at the data for both these vaccines, it's different. Which one seems to work better? It depends on how old you are. So if you're a young child, in fact, it appears as if the live attenuated actually works a little bit better. If you're older, there have been a series of studies done by one group over many different seasons now that suggests that the inactivated is a little bit more effective. Why is that? Well, it probably has to do with these people have prior experience with influenza and influenza vaccine. They're not vaccine naive, whereas these are very naive hosts. So therefore, the live attenuated, stimulates mucosal immunity, and maybe that's more important in your primary infection. I don't really know the whole entire answer. I don't think we quite understand it, but these are the data. So who do we immunize with seasonally? This is a little bit different than what we are talking about with the H1N1 vaccine. So the priority groups are a little different, and I'll explain why a little more when we get to the H1N1. So anyone who really wants flu vaccine can get flu vaccine. There's no restriction on that, except if you're egg allergic. We don't have a vaccine if you're egg allergic. Children 6 months to 18 years of age are a particular target group, particularly individuals higher risk. So the higher risk kids, and I'll show you data to suggest to emphasize that in just a few minutes. So if you're 6 to 59 months of age, if you're over 50, if you're on aspirin therapy, if you have underlying pulmonary or cardiac conditions, if you're immunocompromised, or if you're pregnant. Those are all considered high risk. Or another particular group that we like to focus on, if you're a household contact of somebody who's at high risk, so particularly children or older individuals. And also healthcare personnel should get the vaccine as well. Now, how did these recommendations for children come about? Well, they have evolved over years in practice. So back in 2002 was the first year that we actually encouraged vaccine for the youngest age group of kids. And then the recommendation changed. It became more formal in 2004. This extended up to age 5 in 2006. 2008, it actually extended up to everybody up to 18 years of age. So now we recommend vaccine for the whole age cohort, 6 months to 18 years of age. So this has evolved, and part of the evolution of that has been supply of vaccine. If we had necessarily said that 5 years ago, there wouldn't have been a supply to provide to this whole entire age group. But the other indication, if you looked, and reason why, is risk, and then also who spreads flu. And you can clearly show that school-age children are the vectors for influenza in the community. So if you have campaigns to vaccinate school-age children, you can actually show reductions, and there's been studies done, of influenza in the community when you just vaccinate school-age kids. Particularly, they're the vectors. Those are the ones we need to be immunizing. So the recommendation for kids is a little bit complicated, because if you're under 9 for seasonal flu vaccine, you actually need 2 doses of vaccine 1 month apart. So now, thinking about that, that is logistically very, very difficult. Adults only need 1 dose. If you're over 9, you only need 1 dose. And if you're, had a prior dose, or if in a prior season in your kid, you don't really necessarily need 2 doses. There are some limitations on that. But if this is the first time you're getting vaccine and you're a young child, you need to get 2 doses a month apart. Well, think about that. We see about 1,000 kids per birth cohort year in our practice. That means we have to get 2,000 kids in, or 1,000 kids in twice in a short period of time, in about a month period, to vaccinate them in our practice. Plus, every other kid up to age 18. That's a lot of kids that we have to give flu shots to. So why do we have these recommendations for kids? What proof do we have that it helps? Well, one of the very first studies, and I think, Mary, you were here when we did this, and with Tina, we actually, this is with Dr. Clemens, Dennis Clemens, who was one of the originators of the vaccine unit, and when I very first joined the group, we actually went out to daycares and we immunized young kids in the daycare with flu vaccine. We gave half of them flu vaccine, and the other half we gave actually hepatitis B vaccine, but because it was actually before the recommendation came in to give hepatitis B vaccine. And what we showed is that we could actually reduce the rate of otitis media in that group during the flu season. And when you think about it, it makes sense. You have a kid who gets influenza, they get a lot of runny, snotty nose, everything gets congested up here, their eustachian tubes get blocked, and what happens? Bingo, they get an ear infection. So it really made sense. There are several studies that have actually showed this, and it showed a benefit to immunizing young kids with flu vaccine. The other point I was trying to make is that flu for young kids is not a good thing. And if you look at hospitalization rates, you can see here that hospitalization rates, as you go down in age from 5 to 15, actually increase. If you look at the very youngest group, under 6 months, the hospitalization rates are really high. And actually, if you compare, they're as high as they are in the elderly, in those over 65. And also, if you look at mortality rates, and this is just one particular season, that bad flu year we had in 2003, 2004, you can see here, as you get down in age for kids, the mortality rate went up in that particular season. Well, so these recommendations came about to immunize kids, and we were sitting around thinking, this is going to really be difficult to try and get all these kids in. So, what would happen if you gave flu vaccine in the spring with last year's vaccine, because it's still sitting around in the refrigerator, and you gave one dose in the spring and you gave the new one in the fall? It'd be a lot easier than trying to get all these kids in at one time. And what would happen if you did that and compared it to just the current recommendation of giving 2 doses in the fall? We thought, well, that's a pretty practical study to do. So my colleague and I, Janet England in Seattle, kind of came up with this study and presented it to one of the vaccine manufacturers. Said, it sounds like a good idea. So they actually nicely funded the study. Well, so the study design was we gave a dose of TIV in the prior season, gave a dose in the fall, and followed it up a month later just to give standard of care. And then we gave 2 doses, compared it to a group who got 2 doses in the fall. We enrolled them all at the same time and randomized them to get to either one of these 2 groups. And then we measured sera. Now, we didn't, these are kids, so you can't draw blood every time you want because these are little kids. Their parents won't sign up for the study. They're screaming. So, we have to be a little bit nice. So we limited it to 2 blood draws. So we did one, for the spring-fall group, we did 1 baseline, and we did 1 after dose 2. And for the fall group, we did a sera after dose 1 and then 1 after dose 2. So everybody had, this group, when we compared it, our main outcome was comparing after 2 spring and a fall dose, to 2 fall doses, okay? So the first year we did this study, it would so happen that the vaccines didn't change between the spring and the fall. It was like the only year that I remembered the vaccine didn't change. Well, it was actually to our advantage that happened because then the manufacturer funded us for a second year. So, so we did this study, and lo and behold, we showed that if you got, this is after 2 doses, comparing after 2 doses. This is the spring-fall group and the fall-fall group. Pretty comparable responses. And this is looking at antibody to that hemagglutinin antigen, which is considered to be the standard. So if you got above this level, it's usually generally considered protected. Depends on the assay you do. Some say it's greater than 1 to 32. Some say greater than 1 to 40. So that was our result in the first year. Well, then we thought, we got to restudy this when the antigens change. Well, we were hoping for a little better result, but, we got actually some interesting results. And what they showed is if you change the antigens, actually here for H1N1, they were pretty comparable when you change the antigen and you're comparing the spring-fall versus the fall-fall. However, for the H3N2, it was different. And for the B, it was quite different. So we weren't able to demonstrate. What we demonstrated by that is it's probably better to have 2 fall doses than it is to have a spring and a fall dose. However, I want to point out a couple other things. And this is important when we're talking about H1N1. Look what happens if you just give 1 dose. You get a very little response. And this is considered protective. Very few kids get protected with 1 dose. That's why we give 2 doses. And remember, these are all kids who are probably pretty much disease naive because they're their baseline titers, or their vaccine, and they were all vaccine naive. So you can see, this is current data. How are we doing at distributing all these second doses of vaccine in real life? Because, we're stuck with this policy to now give 2 doses. And actually, we thought we were going to change the recommendation. And the recommendation then came forward from our study and some other studies that If you only got 2 doses, if you only got 1 dose and it was the year before, then you need 2 doses that fall. So they made it even more strict. We thought maybe we would get things liberalized a little bit. But anyway, how are we at giving 2 doses to kids in the fall? Not so good. Only about 30% of kids get both doses in the fall in that age group. About 50% are getting a single dose of vaccine. Now, which brings me to the next point. If you looked, remember I showed you that graph, which kids were at the highest risk for influenza hospitalization? Kids under 6 months, okay? They're the age group for which we don't have any vaccine, all right? Well, why is that? Well, we just recently, we reanalyzed the data from those 2 studies over 2 years and looked at it by age. And you can see here there's a clear trend, and these are kids who were seronegative at baseline. There's a clear trend in every analysis that we've done looking at this data that as the age group decreases, your immune response decreases. So young kids tend not to respond to vaccine as well. So besides the fact that the data aren't there from studying it in young kids. So several years ago, we did undertake a study where we looked at giving vaccine in children at between 6 and 12 weeks of age. We compared the responses to kids who were 6 months of age, and lo and behold, you can see they don't respond as well. But there's a caveat to that, in that a fair amount of these kids, because we did this study in the spring, in the youngest group, had antibody from their mothers. And this data here just shows that if the mothers had had vaccine less than 180 days before birth, we collected that information, that in fact the baseline titers were higher. So when you pull out those kids who had baseline seropositivity, in fact the immune response was pretty comparable. So that led us to do a placebo-controlled trial comparing vaccine versus placebo in young kids. Never like to give placebo to young kids, but we did in this. It was a multi-site study. And these, all the data from these 2 studies are actually going to be published in January and February. But here, these have been presented, and you can see here that responses to TIV versus placebo are higher. About 50% of kids respond in this young 6 to 12 age group, 6 to 12 week age group, with protective level to H1N1, and about 80% respond to H3N2. Responses to B are abysmal, and that is not uncommon in many different age groups. The drug company went to the FDA to say, what about getting this approved for young kids? They want to see efficacy data, so that has yet to come. So until then, what do we have left to do? We vaccinate caregivers. So this is called the cocoon strategy to protecting young kids. We vaccinate everybody around them. So this is the child care provider, the health care worker, parents, siblings, and grandparents. Now, you'd think this would be, for mothers, it would be pretty much a no-brainer. We have a recommendation to vaccinate pregnant women. Yet, if you look at the national data, the latest, only about 24% of pregnant women get flu shots during pregnancy. So it's pretty low. Healthcare workers aren't necessarily a lot better. But there are clear data to show that as you go along in pregnancy, your rate of hospitalizations actually increase. And I think we're seeing a lot of this information obviously emerge with the H1N1 epidemic, that pregnant women are at high risk. So 2 seasons ago, we actually undertook a program at Durham Regional where we offered vaccine to new mothers, fathers, and made it available for siblings at Durham Regional in the hospital. And we were actually able to show that we could increase vaccination rates at Durham Regional. About 40% of women actually had it, reported having it prior during the pregnancy. That was pretty good compared to national data. but we were actually able to increase that rate up to about 70% by offering in the hospitals. Likewise, dads, we got up to about 50%. Okay, I'm going to switch over and now and kind of move on to H1N1. And you can see here, as I mentioned, pandemics occasionally do occur. This is when the virus changes a lot, so there's a big genetic change. And, to my way of thinking, we always have traditionally thought you can look down here of thinking as the subtype changing. You can see here in every change, there's been a change in the type, the number type. So, we went from an H3N2 to an H1N1 for an H2N2 virus to an H3N2 virus to an H1N1. Well, what's happened since these pandemics, since these last two pandemics, since 68, actually H3N2 and H1N1 have kind of co-circulated in the population. So that's why you see that the vaccine actually contains two different strains. It contains an H3N2 and an H1N1. Some years we have more H1N1. Some years we have more H3N2. Some years we have more B. But these were the past pandemics, and as you all know, the 1918 one was the big one of all big ones, which caused the most severe illness. Clearly, we were overdue. So this is the bug, the current bug. It's H1N1. This right here was a triple reassortant swine flu that actually had been around for 10 or 15 years or so, and had been in the swine population, and it occasionally had been transmitted to persons in the U.S. And there had been a limited report of cases, and it was really only transmissible from animals. But you can see here what we have in California was actually something similar to this, but this particular virus actually contained a Eurasian swine lineage. So it actually has genes from a Eurasian influenza in there. Now, the other thing that I think I want to point out here is that the hemagglutinin here actually comes from a swine strain. So it's not like the current seasonal H1N1. So remember I said there was H1N1 in the current vaccine, and this is H1N1, but they're very, very different. And that's what makes this novel and is making it a pandemic. So unlike my classical thinking where you switch over to an H5N something, this one stayed H1N1, but it is very genetically distinct. So what's happened with this virus over time? You can see how the pandemic has spread. And this is activity over the past, I think by 4-week blocks, starting here in August. And you can see it kind of started more in the southeast area, probably as kids went back to school, and has spread and really pretty much has filled in the map. If you look here, I didn't update this slide this week. I've been pretty much updating them weekly, but I didn't change this one. You can see that I think we're past the peak, and actually it's really kind of starting to come down here in North Carolina. So I think we hit the epidemic early, and we're kind of on the downward trend. So what about H1N1 vaccine? Well, this looked very familiar to what I showed you on the earlier slide. So the different manufacturers have come in with vaccines and got licenses for these products and approvals really based on their current licenses for seasonal influenza vaccines. So they pretty much basically just said it was a strain change difference, and that's how they got a quick approval. The last one to come in and just got approval, I believe, 2 days ago, and I heard this because I was watching CNN at night, so I quickly edited this to my slide, was GSK just got approval this week to bring more vaccine for their vaccine. Why did this take so long? They've been making an adjuvanted vaccine, and the United States is very hesitant about adjuvanted vaccines. So they had put a lot of their eggs in, literally, into making the adjuvanted vaccine. But they, I think, somehow eventually agreed to make some non-adjuvanted vaccine to bring to U.S. market. So now there will be 4 inactivated vaccines. Again, only one for the youngest age group, and there is also a live attenuated vaccine as well. Now the target groups, as I mentioned, are a little bit different. Why is that? So here we're targeting, again, pregnant women, people who care for young kids, healthcare workers, and young kids between 6 months up to 24 years. And remember, I said the reason this kind of extends is really it's this young school-age population, and consider that kids up to 21, 22 are still in school, many of them, that are easily spreading virus. So that's really why that recommendation is a little bit different, up to 24 years of age. But the older age group isn't in this cohort. Well, why is that? And this was just in this week's New England Journal article. And this differs from some data that was published, I think, in Nature a few weeks ago that was presented at some meetings. And the data from Europe actually showed that the only people that had protective antibody were really people that were born back before, like, 1910. Back in this earlier. So, it was really, but you had to be really old. So, or before 1910, 1920, I guess. But the data here from the United States suggests that there may be some protective levels, actually, even if, you extend out to people born 1940s, maybe even up to 1950. And there was some preliminary data that the CDC presented in their MMWR that suggested that as well. So it seems to be that older people have some protective level of antibody. Does this explain it all? Probably not. There may be some cross-protection from other antigens, the neuraminidase antigen. This is really only measuring antibody to hemagglutinin. There may be some cell-mediated immunity. But clearly, if you look at the way the current epidemic is, older people seem to be more spared. It's younger people, younger, adults and young children that are being disproportionately affected. The other interesting thing about this paper, which isn't shown here, is if you had the swine flu vaccine in 1976, how many people had that, including myself? I was in college, and we all lined up and got our shot. If you had that vaccine and you were older, you seemed to have cross-protective antibodies to the H1N1 vaccine, or to H1N1. Or a fair number of people did, a pretty high level proportion. If you were younger when you got that, they went back and had sera from that when they did those studies and say reanalyzed it. If you were younger and you got that vaccine and hadn't seen prior influenza illness, probably it was novel at that time, you didn't have cross-protective antibodies. So, young, older, how old was older? Probably if you were over 20. So, so if you were college age and got the vaccine, you probably had some protection. So maybe that's why I didn't get sick in clinic this year. I don't know. So this is kind of flu this year, and I just kind of, lots of questions and tough answers. So what happened when this, we had the vaccine, we knew it was coming, yet it really wasn't very well studied. We didn't have a lot of answers. We knew we were going to have vaccine, but, who are we going to give it to? How many doses did you need? What kind of dose did you need? I've already shown you that young kids, when it's a new, when it's the first time they're seeing it, they don't respond very well. We also knew from this data, from the experience with the H5 vaccine, that people who are getting really high levels, high amounts of antigen in the H5 vaccine, getting 2 doses of it, only 50% of people responded with protective levels of antibody. So it really made us wonder, how much of this, were we going to need 2 doses? So there were a lot of questions to ask. Amount of antigen, number of doses, how was this going to work in special populations, children, pregnant women, HIV, infected persons, persons with asthma. What was going to happen if you gave it with other vaccines, particularly the flu vaccine, and what if you gave it with an adjuvant? So we participated here in these two studies at Duke. The first study was a phase 2 study in adults and elderly looking at giving 2 different dose levels of the vaccine. This is an unadjuvanted vaccine and only one manufacturer. And also we did the same study, same design in younger children in 3 different age cohorts of younger children. So at Duke, we enrolled 130 adults. We enrolled roughly 100 kids in a 5-week period in these studies. So it was pretty intensive work. This was the scheme for following them. Day 1, they got vaccine and blood draw. We called them on day 3. They came back a week later. We called them again, and they got. When they came in again at day 21, got a second dose of vaccine. Came back. We called again at day 3 after. They came back day 8 after the second dose, 3 weeks after their second dose, and then we're in this phase now where we're actually doing follow-up phone calls. So people got randomized to one of 2 doses. One of 2 strengths, 15 or 30 micrograms, and basically everybody got 2 doses of vaccine. We did 5 blood draws in older people. Young kids, we limited it to 3 because we're pediatricians and we're kind. So, and these were the preliminary results that have been reported from this study. And you can see day 8, after one single dose, and this is really looking at the 15 microgram dose, young kids did, and this is the dose that's in the vaccine now, so that's been approved. Young kids didn't really respond that well. As you got to over 10, the response is really the same as in adults, and you can see the older you are, you tend not to respond as well. And this is really true of seasonal flu vaccine as well. So in many ways, this wasn't acting so novel as we might have thought. So in follow-up for the kids, what happens after they get a second dose, you can see here, though they didn't respond very well after 1 dose, they look to be responding after a second dose. This is not the full data set. This is only a partial analysis of part of the study. So the recommendation is that young kids get 2 doses and adults get a single dose. Pregnant women study, this has been done too, similar design, 2 different dosing. And why pregnant women, as disproportionately a large number have been hospitalized and in ICUs. 28 pregnant women so far have succumbed to swine flu. I believe 2 in this state here, 1 I know here at Duke. And you can see here pregnant women respond after 1 dose. And Dr. Geeta Swami actually here at Duke has participated in this particular study. Other studies at other centers looked at giving the H1N1 with seasonal flu vaccine, and it appears as if you can give both vaccines at the same time, regular flu shot with the H1N1. You can space them. You can give it before. You can give it after, and it doesn't matter the time period. So just the point is to give it. There are only one group that we don't know about is if you want to take the mist vaccine, the flu mist from the seasonal, and the flu mist from the H1N1. We don't know what would happen if you gave them at the same time. So it's recommended to space them by about 4 weeks. In most cases, that hasn't been an issue because availability has been limited, particularly for the H1N1. I'm going to leave it at that and not talk about treatment so much, but I do want to acknowledge that the collaborators here at Duke and all the staff that work with me, and I think that's it.
Questions?
I'll try. I don't have all the answers to flus.
Could you just tell me a little bit about the difference between the 1918 H1N1 virus and today's?
and the current H1N1. Genetically, I don't know all the differences, okay, so I can't necessarily speak to that. I think it is fairly distinct from that. I mean, this is a kind of, these things reassort so much that it would be very unlikely that it would be very similar. There's probably some cross-reactivity, and that may be why these people, older people, have some amount of immunity. But it is distinct because there's so much reassorting of the genes that it would be a different virus than the 1918.
So I'll preface this by saying that I'm terrified of needles, and I was one of those people who lined up in the 1970s because my parents drugged me to the high school cafeteria, and they used this little gun where they gave us all the shots.
I got the gun too. It felt weird.
Yeah. So all these years later, I know they have flu mist, but what progress are they making toward some other kind of method of giving vaccines than those old syringes and needles where, I feel sorry for those poor healthcare workers who sit there and do 1,000 of those a day. I mean, they must have some kind of repetitive motion injury.
Yeah, ask the nurses in my clinic who are given lots and lots of shots every day. There are different modes of delivery that are being investigated. Obviously, we have the intranasal vaccine now. We do have, for other immunizations, we have oral administration. For example, obviously for years there was oral polio, but we've made a switch back to inactivated for other reasons I'm not going to get into. We have an oral rotavirus vaccine. There are other nasal delivery systems with different antigens that people have looked at. People are exploring patch delivery systems as well. We've looked at intradermal administration, but I don't know that is much more advantageous than in terms of needles and trying ease of administration than intramuscular. I think ultimately, hopefully, oral may be the route we're able to go, and people have looked at edible vaccines, getting vectors that you can feed to people in a banana, so that they make down the road, but we're a lot of years away from that. So
Chip, we hear about people getting sick and dying. So what actually causes them to die? I mean, you've described signs and symptoms that are don't sound all that severe. So what actually causes the breakdown? What do they die of?
There are a number of different ways people can die from influenza. A lot of them, the virus itself can cause pneumonia, and it can cause a myocarditis in some cases. It can cause just, overwhelming immune response, acute respiratory distress syndrome. A fair number of people in reports that I have read have actually developed secondary complications, so have developed streptococcal pneumonia infections. So which brings the importance of, if you have a high-risk population, making sure that they've had their Pneumovax as well to potentially prevent that complication. Another needle, sorry. Yeah. So there are a number of different, I didn't describe the bad pictures, but certainly, overwhelming infection. A lot of these people have gotten acute respiratory distress syndrome. And I think there were reports, you watch the news reports, you watch people on ECMO, and we've had several people on ECMO here. I deal in the outpatient clinic, so I don't see them so much. I see the lighter end usually of the disease spectrum.
Why do you think that it is so hard to get the 2 doses in at the beginning? Is it, you mentioned supply. Is it supply, or is there difficulty getting the parents to bring the kids back? The appointment in the clinic? What?
I think there are a number of different logistical reasons why we don't get the second dose in.
Or resistance to the parents?
No, if they get the first dose, usually they're willing to do it. I think a lot of them just get busy and don't remember to come back. We don't necessarily give them appointments. Sometimes it is a supply issue, so we'll have vaccine the day they get the first dose, and then we'll run out, and then they'll call back, and we don't have it, and then they don't call back again when we do have it. The supply issue every year is a crapshoot. I will tell you. it's very difficult. So I think that plays into, there's a lot of different factors that play into why kids don't.
Moderator features. Press 0. All participants have been unmuted. You will now rejoin the conference.
Am I muted? So it seems as though daily in the mainline news we're seeing reports of things like, encephalitis and a little boy with flu. Do you think that the media coverage has been appropriate?
Oh, that's a loaded question.
You can say I'm a physician and I don't.
I think if you watch the John Daly show ever, he did a thing about H1N1 coverage, and it was actually pretty funny. I think we give the media gives a lot of very mixed messages, because on one end they will, there are kids who have had neurologic complications from flu, so we do know that occurs. We do know that bad things occur, but bad things occur every year and that's why I tried to show that first slide with flu. But they'll put that on, and then the very next segment will be, don't get your kid vaccinated because they may get, this. This is too new. So, you'll have these two opposing things. We have a lot of parents coming in the office. They'll get the seasonal flu shot, but they won't get the H1N1 vaccine because they say it's too new. What do? I try to reassure them that this vaccine is being made the exact same way we've been making flu vaccine for many years now. It really is a strain substitution with only one strain rather than 3 strains. If I had to pick today which vaccine I would get today, I would get the H1N1, because we don't know what's going to circulate in the spring yet. We know H1N1 is out there. So
that brings a good question, segues into vaccine development. Mm-hmm. I know we've been using the egg model for years. Are there currently any platforms that are close to being approved to get away from those egg syndromes?
Yeah, I've talked to different manufacturers. There is, Novartis is working on cell culture-based vaccine. They actually have built a plant here in North Carolina in Holly Springs, and I think that's the facility in which they plan to produce a cell culture-based vaccine. Then when you talk to one of the other manufacturers who makes vaccine the standard way, they say, well, they're going to encounter many of the same problems that we encounter. Is it going to grow? They'll have to go through the same approval process. It's not only always getting it to grow, although this year it grew slowly in eggs to start off with. Now the manufacturer, when I talk to them, they say that they're making it at regular rates, so it's actually growing fine. But just to start off with, it didn't grow. But once they adapted in cell culture even more, it starts to grow better. So, they say, well, probably the best answer, and I tend to agree, is to have multiple ways we make this vaccine, not just to rely on one simple strategy or one strategy, that it's probably better. And over the years of having done work in vaccines, I can tell you that if you rely on one way, one manufacturer, things happen in manufacturing processes, and I'm not an expert, but all of a sudden that product is gone. And when that product's gone, then and there may be one other product, or there may be no other product on the market, then you have shortages, and then you don't have a product. And we've just, I can't count you the numbers, but we've just recently had a shortage of Hib product because one manufacturer couldn't make, had problems with their Hib production, and so we couldn't boost kids. And not necessarily for that reason, but partially because of that reason, we started seeing some more Haemophilus disease causing meningitis in young kids. So, and there have been several outbreaks now. So there are implications of relying on one manufacturing process. I guess that's my point. But I think you bring up a good point, is that we need to look at alternative platforms. They are being looked at. I think probably the closest one may be that manufacturer, but I don't know how. It's probably several years off.
And also along those lines, as far as children under age of 2, I know RSV is a prevalent. I think it's like 95% of children under 2. But we do have an effective treatment, the MedImmune product. Has there been anything to look at maybe cross reactivity? Maybe is there a prevention or comorbidity with the H1N1?
Well, I mean, I think we're they're pretty different. They're different viruses. So, RSV is respiratory syncytial virus, which causes is the most, as you say, the most frequent cause of pneumonia in young children and respiratory infection. And but it's a completely different virus. So you wouldn't be expected to get any cross protection. The product we use for RSV is a monoclonal antibody that actually will prevent infection. So it's not an active immunogen like we're giving with flu vaccine. So it's just preformed antibody, monoclonal antibody that we're giving to kids to prevent infection. It's very expensive. It's about $1,000 a pop. And so it's really reserved for very high-risk kids who were premature infants, cardiac disease, whatever. We can't really afford to give it to everybody at this juncture. But obviously a good point. Other questions?
Do you think from a physician's standpoint that in this current season that we'll end up being able to vaccinate the number of children that pediatric physicians would really want to be vaccinated?
It's, again, a very good question. The supplies have been very short to coming to our office. So, in fact, we have to date received about, I think as of today, we just got 50 more doses of vaccine. So we've received a total of 200 doses in our office for kids. And part of it's just, how fast it's being made and how it's getting distributed to people in the community. And the distribution plan, this is different than any other vaccine. All the seasonal flu vaccines are made by the drug companies and are either sold to the CDC they negotiate a price from the manufacturer, or they're sold privately in the market, insurance, or somebody else pays for it. H1N1 vaccine, our government paid the manufacturer. Our government owns that vaccine. And as a matter of fact, the manufacturer inadvertently shipped me some for another trial, and they were on the phone calling me at night, the vice president of the company, to get it back because they said the government is counting every dose that is given. So it's being very strictly controlled by the government. But there's a delay in getting it. It comes from the CDC, then the distribution is supposed to go to the state, and then it's up to the state to distribute it, and then the state's distributing it here or there. And, it takes a while. They showed graphs on the lag in that, and it's a good lag in the time it takes to get it out. But will we have it? I'm sorry. To answer your question, I think, we're gradually getting there, but there are many factors to play. Some parents won't want it. We'll be kind of past that initial hump in the epidemic. I would still recommend people get it because I think we're likely to see another peak in this either in the spring or next year. So
do you think masks work? Should we all be walking around with masks?
Should we all be walking? There was a study.
I've seen a few people on the street. That's why I'm saying it.
There's a study in JAMA this week looking at nursing staff. Actually, it compared use of the N95 to a surgical mask because there are not enough N95s. And it showed that they were equally as effective or non-effective, I would guess. I think still 25% of nurses came down with flu, or medical staff came down with flu. I wear one in the clinic when I'm going in to see a kid with respiratory infection now. And, probably maybe we should always be doing that because, kids, you go in to look in their mouths and you're getting the tongue depressor and they cough on you, you get it in your eyes. And so for me it's worked, but I don't know. I wouldn't say we should all be wearing masks.
I was actually kidding.
But there was a study, if you look at JAMA this week.
Okay.
So, any other questions?
Any other questions?
So how many people have had their H1N1 shot yet? Any? No? Can't get it? You're not patient care, right? So how many people would get it if they could get it? Did I convince people get it? Oh, pretty good. Okay. Good. Thanks.
So thank you very much, Chip. That was really great, and I appreciate you coming down
Thank you all.
on a rainy Friday afternoon.